My first talk this morning is on collecting patient outcomes in hip preservation and hip arthroscopy work, so I wanted to share a little bit of thoughts on that and then even a little bit of data of how it can help us as a group. I think when all of us who are practicing in orthopedics recognize what's our big problem as we look to the future, both in terms of reimbursement as surgeons, but also in terms of continuing to have the autonomy to practice in the best interest of our patients. And we recognize that one challenge is that, generally speaking, when you compare to our internal medicine or medical colleagues, is that we are somewhat behind, largely because most of our literature is case series, level 3 and level 4 literature. We sort of know what works, but it's hard to progress along. And one of the challenges has been making sure that we collect robust outcomes for our patients to demonstrate the efficacy of what we do. If you look in the drug design business, and I just put this up here from Mo Bandari, he talks about these ideal stages where things start from an idea and innovation, they go to development, they go to exploration, ultimately assessment and long-term study. And the reason that's important is because when you look at our world, certainly hip arthroscopy has been proven as a technique. We've clearly defined its benefit relative to harm. We've refined and standardized the technique, and we compare with current practices. But our literature needs to correspondingly get from that 0.3 to 0.4 range in order for us to be able to continue to advocate for its success in the longer term in joint preservation. And why is that so critical? I think many of you are familiar with this, which is in general, when you look at payers or hospitals, they will tend to want to question and continue to erode areas that we push forward in. This is a statement for them with regard to hip preservation and FAI. Several case series report improvements in pain, patient-reported outcomes, patient satisfaction, and return to normal activities following FAI surgery. But whether this improvement is a result of the surgery, the post-op rehab, or a change in activity, or whether it's secondary to the placebo effect from all of that is unknown. So when you see those kind of reports, it's obviously disheartening for the group of surgeons in this room that certainly know the value of these interventions for your patients. So what's the end result? How will you continue to learn and assure your care meets the benchmark? Because it's going to be assessed, so you'll need outcomes in your practice to do that. How do you know that you're making the right decisions with multiple options? So is your plan justifiable? Will you have the right input into tools and technology so you can continue to have autonomy over your decision making? And certainly important to all of us, you want to make sure you're reimbursed for all of your efforts so you have the ability to have choice in your practice and not be mandated. And we know that this is coming. Medicare has a quality payment program. In the past, it used to be honorable, if you will, to collect your outcomes. This now turns into where it's in many ways mandatory. And if you don't have these different metrics, you can actually be penalized as of 2019. So that's right around the corner for us, and again, emphasizes the value of having something like SOS in your practice, which allows for real-time collection and feedback from your patient care to not only be able to publish and report on your outcomes, but also to make sure that you're being appropriately reimbursed for your services. CMS has this new quality measure approved. In sports medicine, there's 7 sports medicine-related risk-adjusted outcome quality measures. And certainly SOS has taken this into account to make sure that the outcome scores you would need for hip preservation work are included. So for those of you who aren't familiar with it, definitely familiarize yourself with it because it's something that will allow you to collect this across all of the different demographics of your practice, but certainly in hip preservation. There's 2 different models of SOS. There's the quality assurance, which is more independent of research. There's no IRB oversight. There's no consent. It's truly a collection to assure that you're delivering a high quality of care. With IRB approval and oversight, you can make this a research vehicle in your practices as well. And I know for many of the faculty here whom I learn from, it's their studies that help to drive our next generation of understanding. These are all the different platforms that are available. As you can see here, I'll draw your attention to hip arthroscopy and hip arthroplasty just to the right. It includes a modified Harris hip score, hip outcome scores, the IHOT-12. So it's really a huge number of different outcome metrics, all of which have been validated across our field as the critical metrics we want when we're publishing studies, but also reporting outcomes to our colleagues. And here's the real power, which is each of us are busy surgeons, some more so than others, but none are busy enough to collect this level of patients in the thousands. And as recently as just over the past several months, people have championed to partner with societies. ANA has adopted this as their official vehicle, the Shoulder Elbow Society, and we hope that this will continue with hip preservation through ISHA and other societies as well. What's the huge advantages here? You own the data. You have exclusive rights to use your own data and to export your data, but it allows you to really pool all of the data sets together for you to make more meaningful conclusions. And I think certainly I can speak as a university practitioner. One of the challenges in getting the impetus when you first launch your practice is the threat and the challenge of setting up a registry for yourself. It's hard, it costs money, you need a clinical research coordinator, and SOS has made all of this easy. It's web or cloud-based, it's compatible with your smartphones and tablets. Multiple surgeon sites can be used to pool data together, and again, it takes the onus off of you and off of your overhead to implement this into your practice. It's not just for the surgeon side, though. Patients benefit from this. They're more actively involved in their care. They get instant feedback. Many of the participating surgeons will put these SOS data sheets right on their website, so you can see these are my outcomes after hip arthroscopy, these are my complication rates, and these are what things look like a year or two out from surgery. And so it's really treatment decisions that are based on real-time feedback. And so these are some of the things that you can really help yourself with, right? You can quantify your results. All my patients do well is a common statement, but what do you really do? And measuring you will make you better. It'll motivate patients that are falling behind along their recovery curve to see where they need to be at various time points. And again, at the end of the day, I would argue if you don't have this data, data is king, and it will be hard for you to negotiate with your payers to ultimately protect your reimbursement, not just in hip arthroscopy, but beyond. These are some of the barriers of the past that I would share, at least as I mentioned in my practice. If you try to set up a registry independently, it's expensive. Follow-up is a challenge. If you don't have a research coordinator in your clinics who's going and meeting these patients with every visit, oftentimes you look after a year and 70% follow-up is our metric for publication. This idea that it's only happening at the ivory towers, you can't do this if you're in private practice. Only universities invest in this. And I think all of this is no longer valid with the SOS system because you can do it in real time. This is an example of what it's done, for example, on the shoulder side, where you can see you get this sort of data. You can collect OR time, patient-reported outcome scores, structural integrity. And again, this is valuable data which your health system may not share with you to advocate for the type of products you use. All of us know that a minute of OR time can be anywhere between $80 to $150 a minute, and that certainly factors into the cost equation. So what can you accomplish if you use this system? I wanted to share this data set relative to hip preservation with all of you. I certainly don't have 700 hips in a year. I know some providers here do, but that's not my practice. I maybe have 150 or 200. But when you look at this kind of pooled data set through the anchor group, many of whom are SOS participants, this is the kind of data we get. 700 hips with a year follow-up. We have all of their radiographic data. We have all their demographic data. And then we can report patient-reported outcomes like this, where we know that at a year out with statistical significance less than 0.001, we have improvements in our hip outcome score, our WOMAC score, our modified Harris hip score. So we can go to payers and argue that our reimbursement here should really be no less robust than any other surgical care that renders this level of outcome. And we can show them that greater than 70% of our patients achieve the MCID by their gold standard, the modified Harris hip score. Then as we embark on new areas like revision hip arthroscopy, we can do studies like this that show, believe it or not, despite all the challenges with adhesions, the concern for labral reconstruction, residual deformity, in fact, there's no difference in potential improvement. Our delta improvement in those scores across all these different metrics was every bit as good, but we need large data sets and numbers to do this. As all of you are aware in this room, there's the continued debate is that are our surgeries as good arthroscopically as our open surgical colleagues? Well, here through large data sets, we have 400 arthroscopic surgeries, over 200 surgical hip dislocations. Again, across the board have shown that our outcomes are as robust as a hip dislocation across these FAI populations. And then even deeper questions like gender. All of us know that females and males respond a little bit differently. In fact, we can now actually say conclusively, females do less well by absolute patient-reported outcomes. But we can dig into this deeper and point out this actual relationship, which is the reason they do less well at the end is they start less well to begin with. So their delta is actually more improvement than a male, but their absolute patient-reported outcome is less good at the end. So when you go to your payers or you go to your practice, you can advise them that just because your final absolute PRO is less good doesn't mean that your delta improvement or MCID didn't meet the metric. So I'll conclude by saying that surgical treatment for FAI with these kind of outcomes is really critically important, and it's important for all of us to collect this data. SOS will allow you to collect this so we can make these conclusions to continue to advocate for us as a physician group. Revision surgery does have validity. Surgical dislocation is very effective, but not more effective than hip arthroscopy in this patient population. There are gender differences, but we need to dig into those deeper to point out just exactly what those differences mean. And in the end, your preoperative scores and a good correction of your deformity seem to be the most important and consistent predictors of a good outcome. So in general, I just point out and really emphasize that outcomes matter. Data is our power with our health system. It's our power with our payers and for reimbursement. And SOS has become a very, very simple vehicle for us to be able to do this. And if you haven't done this in your practice, I would encourage you to do so. Thank you.